Assalamu alaikum. My name is Muhammad Osama Osmani. I am a student of 5th Prof Morning in the University of Karachi. My roll number is BP1650149, and the topic that I will be presenting today is antiretroviral therapy, with particular focus on a single antiretroviral, which is a combination of emtricitabine, efavirenz, and tenofovir, commonly known as ARRATIONAL. This presentation has been divided into 7 parts. We will start off by discussing very briefly what is HIV and what is the difference between HIV and AIDS. We will then move on to what is antiretroviral therapy and the different types of antiretrovirals. Along with that, we will also look at the goals of antiretroviral therapy. With that covered, we will then move on to the indication, contraindications, irrational use, adverse effects, dosage forms, and drug-drug interactions of emtricitabine, efavirenz, and tenofovir. At the end of the presentation, there is a case study for which I have prepared soap notes, which I will be sharing. Starting off with what is HIV and the difference between HIV and AIDS. To state it in a very concise manner, HIV is basically an RNA virus which attacks the body's immune system, especially the immune T cells. An HIV positive patient does not necessarily have AIDS. The natural progression of HIV is such that there is an acute infection followed by an asymptomatic stage or latent phase, after which, when the CD4 count drops, they become symptomatic, and then some people progress to AIDS, which is acquired immunodeficiency syndrome. AIDS is defined as being HIV positive and having one of the age defining illnesses such as opportunistic infections, wasting syndrome, Kaposi sarcoma, or having a CD4 count less than 200. Now, what is antiretroviral therapy? Antiretroviral therapy, or ART for short, is recommended for all HIV patients for a variety of reasons, which include reducing the viral load in the body, reducing the morbidity, prolonging the survival of the individual, restoring and preserving the immune function, and also preventing the viral transmission in patients that have a viral load less than a detectable limit. Now, if you look closely at the diagram, this is basically the mechanism of HIV replication. It undergoes 7 stages or processes. The first one being binding, then fusion and uncoating, then reverse transcription, integration, translation, assembly and budding, and finally maturation. Our different antiretrovirals target different sites. Let's start off with fusion inhibitors. These prevent the fusion of the HIV receptors to the receptors of the immune T cells. These are only recommended when there is treatment failure. An example is antiretroviral. As you can see, this is the site or stage where the fusion inhibitors are acting. Next, we have the CCR5 antagonists. These drugs prevent the virus from entering the target cells by blocking the CCR5 receptor. Examples or an example of CCR5 antagonist is maraviroc. Then we have NRTIs and NNRTIs. Basically, these are nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. Both of these block the action of viral reverse transcriptase, but the only difference is NRTIs do that competitively, whereas NNRTIs do that non-competitively. An example of NRTIs is basically abacavir and emtricitabine, whereas NNRTIs include doravine and efavirenz. Next, we have integrase inhibitors, which target the integration stage. These block the use of a protein by the HIV, which is known as integrase. Integrase is necessary for the HIV virus to integrate into the genetic material in the cell that it is targeting. And now at the very end, we have protease inhibitors, which target another viral enzyme, which is important for the HIV, known as protease. This is required by the HIV to mature into infectious virions. Some examples of protease inhibitors include atazanavir and darunavir. Now, what are antiretrovirals? Antiretroviral therapy involves taking antiretrovirals in a manner of combination each day. An HIV treatment regimen usually involves at least 3 different drugs from 2 different classes, as we have seen previously. These are the drugs that we discussed: NRTIs, blocking the reverse transcriptase. Then we have the NNRTIs, non-competitively blocking the reverse transcriptase. Then we have protease inhibitors, which inhibit protease, followed by the CCR5 antagonists, which prevent the virus from entering. We have the fusion inhibitors, which prevent the fusion of the HIV virus to the receptors of the T cells. And finally, we have the integrase inhibitors, which target the integration stage of the HIV replication mechanism. Now, moving on to the goals of the antiretroviral therapy. The goal is to keep the viral load below the line of detection, which is less than 40 copies per ml. The viral load should decrease tenfold within 4 to 8 weeks and should be undetectable by 6 months. These are usually given as a combination, preferably in a single pill regimen, for example, 2 NRTIs plus 1 integrase inhibitor or protease inhibitor. This is the preferred therapy for treatment naive patients. Now, treatment naive patients are those that have never undergone antiretroviral therapy before. Now, moving on to the major drug, that is the emtricitabine, tenofovir, and efavirenz. In this, emtricitabine is an NNRTI. Sorry, efavirenz is an NRTI, while emtricitabine and tenofovir are NRTIs. What are the indications and contraindications of this drug? Emtricitabine, tenofovir, and efavirenz is indicated for use alone as a complete regimen or in combination with other antiretroviral agents, either protease inhibitors or integrase inhibitors, for the treatment of HIV-1 infection in adults and pediatric patients 12 years of age or older. These are contraindicated in hypersensitivity and with concurrent administration of voriconazole or elbesivir. The irrational use of this drug includes: in South Africa, there is a drug cocktail known as Bunga. It is rumored to contain emtricitabine, efavirenz, and other HIV antiretroviral medication. Its use may adversely impact adherence to HIV treatment and may have the potential to generate ARV antiretroviral resistance. There are various adverse effects of this drug, with some noteworthy being psychiatric events such as depression, lipodystrophy, Stevens-Johnson syndrome, hypercholesterolemia, somnolence, vivid dreams, nasopharyngitis, hypertriglyceridemia, along with the more common ones such as dizziness, fatigue, insomnia. This drug is available as a tablet in 600, in which 600 mg is of efavirenz, 200 mg is of emtricitabine, 300 mg is of tenofovir, and available as a tablet, as previously mentioned. The different brand names in which this is available. Firstly, this drug is not available in Pakistan, hence the price has been given in dollars. Secondly, this particular combination is only available as the AAA. There are other antiretroviral combinations, but they don't contain all 3 of the drugs of interest right now, which are efavirenz, emtricitabine, and tenofovir. As you can see, AAA is quite expensive, with one tablet costing about $100. There are Truvada is a cheaper alternative, but does not contain efavirenz in it. Well, the different drug-drug interactions include with alcohol, or such as alcoholic beverages. Then we have azithromycin, ciprofloxacin, erythromycin, rifampin, sulfasalazine, tobramycin, tramadol, and so on. Moving on to the case study. Sally Smith is a 27-year-old woman diagnosed with HIV infection 2 years ago during a routine exam. At the time of diagnosis, the patient was asymptomatic. During the 2 years since her diagnosis, her disease has been stable with regular clinic and laboratory follow-ups every 4 months. Today, she returns for a routine follow-up visit. She has a history of crack cocaine use, which was last used 3 years ago. She uses tobacco, drinks on weekends, is employed at a candy factory, is sexually active with a stable partner with 100% condom use, who the partner is HIV negative and is aware of her HIV status. She uses multivitamins once daily and Pepsid 20 mg PRN. Her vitals are BP is 107 by 54, pulse is 68, respiratory rate is 18, temperature is 36.4 degrees centigrade, weight is 55 kg, and height is 5'2". This is a 27. Now, moving on to the subjective. This is a 27-year-old female presenting for a regular follow up every 4 months. Patient is currently doing well. She has a past history of an HIV positive diagnosis made 2 years ago during a routine exam. The patient has a past history of appendectomy at age 15. Smoking is positive. She drinks alcohol. She has a history of crack cocaine use. Patient is in a monogamous heterosexual relationship with HIV negative partner with consistent condom use. The patient is currently not on any antiretroviral therapy and is taking Pepsid and multivitamins. And there is no significant family history. In the objective, her vitals are BP is 107 by 54, temperature is 36.4 degrees centigrade, respiratory rate is 18, pulse is 68, weight is 55 kg. Her BMI is 22.1, her height is 5 feet 2 inches. Patient is alert and oriented, anicteric with no wasting. She has a large tattoo on the back of her neck. Her left LN is 0.5 centimeter palpable. Cardiovascular, respiratory, neuro, GI, and GU exams are non-significant. These are her labs. We'll be coming back to these soon. Assessment: 27-year-old asymptomatic HIV positive treatment naive female progressing to acquired immunodeficiency syndrome with decreasing CD4 counts and increasing viral load. Now, before starting with the plan, let's go back to her labs. As you can see, there is a rapid decline in her CD4 count, which shows a breakdown in her immune function. This is very significant because if her CD4 count drops below 250, she is at risk of opportunistic infections, and we will have to start her on prophylactic antibiotics. The target in an HIV positive patient is to have less than 40 copies per ml. And as you can see, since her copies are about 350,000, this shows that her viral load is very high, and this can cause increased morbidity and mortality. A good thing is, in her previous antiviral resistance testing, no resistance has been detected, which shows that she is a good candidate for any antiretroviral therapy. Her hepatitis virus tested negative for both antigens and antibodies, which means she has not been previously immunized for hepatitis B and hepatitis A. Moving forward, this is something we would like to ensure that she is immunized to protect her from these viral infections. There is nothing noteworthy in her CBC. As for the pharmacotherapy, we will start her off on emtricitabine tenofovir in a single pill combination, oral, once daily on an empty stomach, and this will be continued indefinitely. As far as the education and counseling of the patient goes, we will educate the patient regarding HIV and AIDS, including the possibility of opportunistic infections. We will counsel the patient on the need for medication compliance and the avoidance of drug holidays. We will counsel the patient regarding safe sex practices and disclosure of HIV status to partners, and also regarding the safe use of needles and drug sharing in drug sharing practices. As for her healthcare maintenance, there will be regular follow-ups every 3 to 6 months with CD4 counts and viral loads. Her psychosocial concerns will be assessed, and she may be referred to psychiatry or social work if appropriate. As for her vaccines, she will get influenza annually, 23-valent pneumococcal every 5 years, HBV, HIV, and HPV. She will be annually screened for pap smears and STIs. management of comorbid condition and provision of general primary care. As for laboratory assessments, baseline tuberculin skin test (PPD) in duration greater than 5 mm is positive. There will be baseline toxoplasma, syphilis, cytomegalovirus, and varicella zoster virus. Annual fasting lipid profile and fasting glucose due to the side effects of antiretrovirals. All of these will be conducted as her laboratory assessments. These are the references from which this presentation was made from. Thank you for your time. Allah Hafiz.